Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
We're thrilled to bring you all our last episode from our core curriculum series. We're going to be discussing survivorship following gynecologic cancer. We'll take a brief publication break after this episode, and then we'll be back. Our plan moving forward is to periodically update our existing episodes, to stick with our goal of providing you all up-to-date content, which includes current knowledge and practice patterns. We're also going to start to create new episodes, and we'd love to hear from you. Are there topics that you wish we had already covered? Subtopics that you think deserve some more time? This first season has been a fulfilling and educational journey, and we're so grateful to have shared it with you. This podcast is for you, so please let us know your thoughts for future episodes by filling out the feedback form on our website at readysetgyo.com. Additionally, please leave us a review on your preferred podcast platform. These are very helpful to improve visibility of our show.
For today's episode, we have an exciting guest host, Skye Jacobson. Skye has been responsible for our website creation and social media management since the beginning. As part of a research elective during her 4th year in medical school, she thoroughly researched gynecologic cancer survivorship and created today's episode script. Skye is a new OB/GYN intern at Mountain Area Hospital Education Center, and we are very excited that she'll be continuing to work with us during residency. Skye, why don't you share our learning objectives for today?
Hi, listeners. First off, I've loved being a part of the show, and I'm still in awe that I get to call Sydney and Maya my colleagues now. I'm grateful to have been able to create a podcast episode and join you to talk about this very important topic. Our learning objectives for today are to 1. Define survivorship and survivor in the context of oncology. 2. Highlight current recommendations for how to manage a patient in surveillance, including the structure and key components of a typical visit. 3. Define hormone replacement therapy versus hormone therapy and discuss current best practice recommendations for hormone administration for patients in survivorship. And 4. Suggest ways to create a toolbox that listeners can use as both generalist and gynecologic oncology providers for their patients. We're going to start today's episode by defining survivorship through the lens of oncology. Take us away, Sydney.
Survivorship is a large term with many different facets. According to the Office of Cancer Surveillance, OCS, and National Coalition for Cancer Survivorship, NCCS, patients with cancer are defined as survivors from the time of diagnosis onward, with a goal of encompassing the whole individual and their care journey. Survivorship care encompasses the potential impact on physical and mental states, health behaviors, professional and personal identity, sexuality, and financial impacts of undergoing treatment for malignancies. It's important to acknowledge that many patients do not identify with or prefer to use the term survivor, so it can be helpful to explain to patients that this term is meant to identify the community of people who have a history of cancer. From a practical perspective, we often talk about survivorship as the care of health, wellness, and quality of life that occurs after patients complete active cancer therapy. But in the era of maintenance therapies, many of our survivors who are living with cancer may be on long-term therapies. As in the cancer-directed phase of care of those with gynecologic malignancies, survivors of any malignancy are at heightened risk of numerous health conditions, both physical and biopsychosocial. Thus, survivorship additionally encompasses proactive screening and prevention. For example, bone health, sexual health, cardiovascular disease, secondary malignancy risk, and psychosocial outcomes. Strategies for screening should take into account the original cancer etiology and therapies received. Providers should think of survivorship as a phase of active care rather than a passive monitoring period. It's also worth noting that survivorship is not just about the patient themselves. It also extends to caregivers and families who often experience distress, role changes, and financial impacts. Incorporating caregiver support into survivorship programs can strengthen outcomes for patients.
How to do this? There are numerous proposed models for how to have comprehensive post-treatment support for patients. The 2024 National Cancer Survivorship Standard was proposed as a model for health systems to create or align with their own survivorship programs. There are three realms covered by the standards, including health system policy, health system processes, and health system evaluation and assessment. This division aims to showcase how to improve the delivery of survivorship care. The newest NCCN guidelines for survivorship, published in 2021, delineate six main components of care of the cancer survivor. Maya, can you walk us through the first two?
Of course. First, survivorship care includes the surveillance of patients for recurrence of and/or development of new malignancies. The NCCN provides surveillance timelines and recommendations for patients following their primary gynecologic cancers. The Society of Gynecologic Oncology released additional surveillance recommendations, most recently updated in 2017 by Solani et al., and these can be used in conjunction with the NCCN guidelines to inform timeframes and format of surveillance visits. During this episode, we'll reference both of these to briefly review the recommended visit intervals and components depending on the primary cancer. For a flowsheet version of this information, check out the NCCN guidelines, which is free for providers. Despite recommendations for less intensive surveillance from SGO, studies indicate that surveillance is often done more frequently with more studies performed than is recommended for gynecologic malignancies. And this can have costs which outweigh the benefits to patients and healthcare systems. Skye, can you give us a refresher on surveillance modalities and recommendations by disease site?
Sure. A theme for many of these disease sites is that surveillance in the early years after treatment is more frequent and intensive than later on. This is the result of many malignancies having a higher risk of recurrence during this time. Another theme is that imaging is usually not recommended in the absence of symptoms. This is an important counseling point. Many patients expect routine scans and may feel nervous when imaging isn't ordered. Setting expectations early, that history, review of systems, and pelvic exams are the recommended data pieces during surveillance, can help reduce anxiety and build trust. Let's start with endometrial cancer, in which the vast majority of recurrences will be diagnosed within 3 years after primary treatment. Surveillance visit intervals differ depending on risk, low risk versus high risk, the latter being defined as advanced stage or high risk histologies. For low risk, visits are recommended every 6 months during the first year, every 6 to 12 months during the second year, and then annually. For high risk, visits are recommended every 3 months during the first 2 years, every 6 months from years 2 to 5, and then annually thereafter. For both groups, after 5 years, annual visits are recommended, but can be performed by either a gynecologic oncologist or an OB/GYN specialist. These visits should simply include history and physical with a pelvic exam. Pelvic exams are crucial as the vaginal cuff is a common and high-risk area of recurrence. Imaging should be reserved for patients who have worrisome symptoms or physical exam findings to determine recurrence and to localize the site of disease. CA-125 can be helpful in patients with high-risk disease or who have had an elevated CA-125 before treatment, but shouldn't be performed routinely. Cytology as a means to detect vaginal cuff recurrences is not recommended, as it does not improve the ability to detect recurrences compared to history and physical exam. Remember, most recurrences in endometrial cancer present symptomatically, so teaching patients what to watch for, such as vaginal bleeding, pelvic pain, weight loss, is a crucial part of survivorship visits. Conversely, for patients with a history of uterine sarcoma, imaging is recommended every 6 to 12 months initially, given the very high risk of relapse.
For surveillance of epithelial ovarian cancer after receiving primary treatment, the NCCN recommends visits every 2 to 4 months for the first 2 years, 3 to 6 months for the next 3 years, and then annually after 5 years. Each visit should include a thorough history and physical exam, including a pelvic exam. According to the 2017 review by Solani, 50% of recurrences were detected by symptoms and 60% were detected by physical exam. In addition to an H&P, tumor markers that are specific to the type of ovarian cancer can be helpful. In our ovarian cancer part 3, late stage and recurrent, we did a deep dive into monitoring CA125 levels and how to define a recurrence. Head back to that episode for more details. The takeaway is that we don't recommend diagnosing or treating recurrences based on an isolated CA125, but it sometimes can be the first marker of a recurrence and can be supportive of other findings. Typically, changes in CA125 lead to imaging, which can detect recurrence. Imaging is not routinely recommended for asymptomatic surveillance, but should be performed when clinically indicated. The 2017 surveillance guidelines from SGO highlighted that this recommendation is not routinely followed, and many providers do incorporate routine imaging for surveillance, which is associated with almost a doubling of the cost to the healthcare system. This is another area where shared decision-making matters. Some patients find reassurance in imaging, while others experience, quote, scanxiety. While there is insufficient data to support routine use, such as in this case, we should balance guideline-based care with patient-centered counseling.
For malignant germ cell tumors, which have a much higher recurrence rate, a more frequent evaluation schedule is recommended. Surveillance with clinical evaluation, tumor markers as applicable, and imaging with CT chest, abdomen, pelvis is recommended every 2 to 3 months for the first 2 years, every 6 months during the 3rd year, and every 12 months thereafter. For malignant sex cord stromal tumors, granulosa cell being the most common, surveillance is dependent on whether the disease is early stage, low risk, or high risk disease. Recommendations include a physical exam and tumor markers every 6 to 12 months for low risk disease and every 4 to 6 months for high risk disease. These exams continue indefinitely because recurrences with this disease site can occur much later down the road. Imaging is reserved for patients with symptoms, elevated biomarkers, or suspicious findings on physical exam. For borderline ovarian tumors, recommendations follow those under the general guidelines for ovarian cancer, except for in 2 special cases. In patients with stage 1 borderline tumors that undergo recommended surgical management, bilateral salping oophorectomy and hysterectomy, there is not an indication for further surveillance aside from an annual visit. If they had fertility-sparing treatment, serial pelvic sonography is recommended, typically every 6 to 12 months, with the addition of tumor markers only if clinically warranted.
Cervical, vaginal, and vulvar cancer surveillance follow similar paths, which rely heavily on the history and physical. In cervical cancer, 50% of recurrences will present symptomatically. Patients should be seen every 3 to 6 months for the first 2 years, then every 6 to 12 months for the next 3 years, before being seen annually based on recurrence risk. Cytology to detect cervical cancer recurrences is an interesting topic. Retrospective studies have not shown cytology alone to be very sensitive for recurrence, with limited additional benefit on top of physical exam. In the 2017 SGO guidelines, cytology was listed as an option to perform annually. However, it was noted to have insufficient evidence to use for detection of cancer recurrence. They noted that patients who are immunocompromised may derive greater benefit from cytology. Similarly, the NCCN guidelines note cytology as an option to be used, quote, as indicated, and point out that the accuracy of cytology results may be decreased in patients who have previously received radiation. Vulvar and vaginal carcinoma generally adhere to the cervical cancer surveillance guidelines due to limited available evidence on recurrence rates and optimal surveillance strategies. In vulvar carcinoma, long-term surveillance as well as patient education on symptoms is crucial as there's a risk of late recurrence. Aside from surveilling for cancer recurrences, what else should we make sure to incorporate into survivorship care?
Great question. In addition to monitoring for recurrence or development of new primary gynecologic cancers, we also need to monitor for and discuss long-term effects of cancer, long-term effects of cancer-directed therapies, and provide information and support that aligns with our patients' goals and desires. This is also where survivorship care plans can be helpful. These are structured documents that summarize a patient's diagnosis, treatments received, and recommended follow-up. These can be shared with both patients and other healthcare providers. While uptake in gynecologic oncology is still limited, they have been shown in other cancers to improve coordination and patient satisfaction. For long-term management of symptoms related to cancer-directed treatment, like neuropathy or late-stage radiation complications, refer back to our chemotoxicities and radiation toxicities episodes. As we've discussed throughout several episodes, if a patient's fertility has been impacted by their cancer or cancer treatment, make sure to refer them to an infertility specialist if applicable and desired.
Let's talk first about sexual health and functioning after cancer and cancer treatment. This can impact a large majority, up to 90% in some studies, of women with gynecologic cancers. This is a hugely important topic as most treatments for gynecologic cancer have the potential to cause sexual dysfunction, but it may not be brought up spontaneously by patients. We need to take the responsibility to ask our patients these questions directly. See more about how to do so effectively in our clinical trials design episode. Sexual function is biopsychosocial and can be impacted by physical symptoms, anatomical changes, interpersonal relationships, or patients' perspectives of their bodies and self-image. Try to get an understanding of where the issue is stemming from and whether treating these issues is something in the scope of your practice, like prescribing vaginal estrogen, moisturizers or lubricants, or dilators, as well as whether referral to a sexual health specialist is warranted. Many times, screening for and identifying the problem, normalizing it with the patient, and referring to a specialist is incredibly impactful. At Maya's residency program, they had a sexual health clinic specific to cancer survivors, which was a wonderful resource for patients. When a resource like this isn't available, other specialties, such as urogynecology, urology, and vulvar specialists may be able to offer services for sexual health concerns. Knowing your referral network is key. Individual and couples counseling is often really helpful and can be suggested for patients who are interested. Pelvic floor physical therapy is also a helpful resource for patients experiencing pain with intercourse or vulvodynia. All patients, whether sexually active or not, should be asked about genitourinary symptoms, including vulvovaginal dryness and irritation. Vaginal dryness can be treated with non-hormonal vaginal moisturizers, vitamin E, hyaluronic acid, natural oils, and lubricants. Silicone-based or natural oils are recommended in this population for sexual activity. Moisturizers are used a few times per week in an ongoing fashion, while lubricants are reserved for sexual activity as needed. If a patient has a hormonally sensitive cancer, then these can be tried as a first-line therapy. Nearly all patients with vaginal dryness benefit to some degree from vaginal moisturizers and lubricants. If using vaginal moisturizers or vaginal estrogen, patients may sometimes experience light spotting, so make sure to warn them about this. If these aren't effective, the next choice is to prescribe vaginal estrogen, which is safe and effective. Most of the data about the safety of vaginal estrogen in the setting of hormonally responsive cancers comes from breast cancer. At ASCO 2025, there was a large abstract presented which used SEER Medicare data of nearly 19,000 patients with breast cancer and showed improved overall and breast cancer-specific survival in patients who used vaginal estrogen, which adds to the data that this is safe. The circulating levels of estrogen in patients with vaginal estrogen generally remain in the menopausal range, but there is a black box warning on vaginal estrogen about a potential increased risk of breast and endometrial cancer. This black box warning is often confusing for both providers and patients. Gynecologic oncology practitioners should be ready to contextualize it, emphasizing the difference between systemic hormone replacement therapy and local vaginal estrogen therapy, and that available evidence supports safety in gynecologic oncology survivorship.
In addition to sexual functioning, it's important to talk about an intertwined topic: menopause. Many of our patients may have undergone natural menopause prior to treatment, but others may experience surgical menopause as a result of treatment, and some experience temporary menopause symptoms related to ovarian suppression. Each of these scenarios has specific aspects to consider. Maya, what can you tell us about the use of hormone replacement therapy and hormone therapy for menopause symptoms in our patients with gynecologic cancers?
Induced menopause, defined as cessation of menstruation and ovarian function due to surgical removal of the ovaries or due to damage of the ovaries from radiation or medical treatment, has been associated with increased risk for osteoporosis, heart disease, and cognitive decline and dementia. With menopause from any etiology, patients may experience bothersome symptoms. Vasomotor symptoms, described as a sudden sensation of extreme heat in the upper body, which typically lasts between 1 to 5 minutes, are common. These typically occur quickly, within 24 to 48 hours, in premenopausal patients who have undergone a BSO. Having a plan in place ahead of time and good preemptive counseling can be really helpful. Patients might also experience fatigue, changes in mood and libido, cognitive changes, difficulty sleeping, appetite, and weight changes. There are many non-hormonal options for the management of vasomotor symptoms. These include SSRIs, SNRIs, gabapentin, clonidine, and NK3 receptor antagonists. Paroxetine 7.5 milligrams daily is FDA approved for vasomotor symptoms and can be good for patients with concurrent depression and/or anxiety. Similarly, venlafaxine is one of the most studied agents as an off-label treatment. Consider clonidine in patients with hypertension that's not controlled with other meds, and consider gabapentin for those who also have neuropathic pain or insomnia. Fezolinetant, a first-in-class NK3 receptor antagonist, was FDA approved in 2023 and can be a good option in those that SSRIs or SNRIs are not tolerated. Generally, it is recommended to consider a trial of non-hormonal options first in postmenopausal patients with bothersome vasomotor symptoms and a history of gynecologic cancer before moving on to hormonal therapy. Also, don't forget non-pharmacologic behavioral and lifestyle interventions. Cooling measures, including layered clothing and fans, weight loss, especially in overweight patients, mind-body interventions like pace respiration, mindfulness-based stress reduction, CBT, and avoidance of triggers like alcohol, spicy foods, caffeine, and hot beverages can also be helpful.
I have a question for the team, something I needed a refresher on starting residency and as I was researching this topic. Can we go into the difference between hormone replacement therapy and hormone therapy?
Yeah, we wanted to spend some time talking about hormone administration. First, some terminology. Hormone replacement therapy refers to the administration of hormones to premenopausal patients who have undergone premature menopause for any reason, with an attempt to restore physiologic levels of hormones. Hormone therapy refers to administration of hormones to postmenopausal patients at lower doses for the purpose of treating bothersome symptoms of menopause. There are various forms of administration of all the hormones, which is beyond the scope of this podcast, but there are excellent podcasts and other educational resources out there to review hormone prescription, and we'll link some on the website. There have been and continue to be extensive studies and conversations regarding hormone therapy for patients after menopause, with and without cancer. The Women's Health Initiative was the pinnacle study evaluating hormone therapy for chronic disease prevention in postmenopausal patients, and it demonstrated an increased risk of breast cancer, coronary heart disease, stroke, and VTE, with decreased fracture risk in those taking hormone therapy. There is a lot of controversy about the results of this study, which had an average age of 63 years, which is older than we currently recommend starting hormones, and administered relatively high doses of hormones. Several follow-up studies have clarified best practices for hormone therapy, and today we're going to focus on issues specific to gynecologic cancer survivors. The North American Menopause Society, or NAMS, has several consensus statements with specific sections discussing patients with cancer, and the most recent edition was released in 2022. The gist of their message includes reiterating that hormone therapy remains the most effective treatment for vasomotor symptoms and genitourinary syndrome of menopause, and that hormone therapy has been shown to prevent bone loss and fracture. It goes further to say that treatment should be individualized using the best available evidence to maximize benefits and minimize risks, with periodic reevaluation of the benefits and risks of continuing therapy. The Society of Gynecologic Oncology published a clinical practice guideline in 2020, and a new review was published in 2025 by Gorman et al. In Current Treatment Options in Oncology, with updates on hormone treatment specifically for gynecologic cancer survivors.
Guy, can you walk us through available evidence on hormone therapy for gynecologic cancer survivors?
Yes. Recall that we've already discussed vaginal estrogen, which is generally viewed as safe in patients with a gynecologic cancer history and does not appear to increase recurrence risk, although we should discuss risk and benefits with our patients. Let's review recommendations for systemic hormone therapy. As with all patients, we recommend that the lowest possible dose of therapy is taken for the shortest period of time to achieve symptom management. For our discussion, we'll be focusing mainly on safety in regards to cancer recurrence or progression. And remember, survivorship care isn't one size fits all. Age at diagnosis, tumor biology, and patient values all weigh heavily in hormone discussions. Endometrial cancer, which is often hormonally responsive, is one of the most challenging gynecologic cancers for hormone therapy discussions. Traditionally, this has been avoided for patients with endometrial cancer. However, existing data demonstrates that, especially in the setting of early stage, low grade disease, the increased relative risk of hormone therapy may be minimal and can be considered. A 2006 randomized control trial performed by the GOG aimed to evaluate this question. While the study was closed early due to the publication of the Women's Health Initiative, the absolute recurrence rate for those who received hormone replacement therapy was 2%, which advocates for the safety of estrogen administration. Additionally, retrospective data demonstrates potential safety of leaving the ovaries in situ for premenopausal patients with early stage, low grade endometrial cancer. In patients with later stage or higher grade disease, there is very little data to inform us, and so at this time, generally hormones should be avoided. Ovarian cancer is a less hormonally responsive disease, and the use of hormone therapy after treatment for most epithelial ovarian cancers, based on existing literature, does not seem to increase the risk of recurrence. In fact, the majority of studies, including prospective studies, actually support a survival benefit in patients who receive hormone therapy after treatment for ovarian cancer. However, in patients with hormone-dependent ovarian cancers like granulosa cell tumors, low-grade serous, and endometrioid, hormone therapy is generally not advised. In patients with borderline serous tumors who have had complete resection, especially those with early-stage disease, hormone replacement therapy can be safely prescribed when acknowledging that there is limited data supporting this. Cervical cancer, vulvar, and vaginal cancers also represent non-hormonally driven disease sites in which hormone therapy and hormone replacement therapy should be considered, especially in premenopausal patients. These are often easier survivorship discussions where safety data is reassuring and quality of life benefits can be significant. The 2025 Gorman et al. Review article referenced previously highlights starting doses for use in these lower risk patients. Check out our website for more information.
What about hormone replacement therapy for patients that undergo prophylactic bilateral oophorectomies?
We discussed this in our hereditary cancers episode, so head back there to review. To reiterate, for patients with no history of malignancy but who underwent prophylactic oophorectomy for cancer risk reduction, hormone replacement therapy is safe, effective, and should be routinely prescribed. This is true for patients with and without genetic predispositions to cancer. Because of the risks of cognitive dysfunction, heart disease, and osteoporosis with early surgical menopause, it is crucial to prescribe hormones and to educate our patients and our colleagues about their safety in this population. As discussed, make sure to dose these patients appropriately, not with low-dose postmenopausal regimens. If patients have a concomitant breast cancer history, this question becomes more nuanced and should be managed in conjunction with the patient's breast oncologist. What other topics are important to discuss with survivors?
Thanks for asking. Other important history questions to ask patients about include issues regarding exercise, nutrition, weight gain, and attendance of primary doctor visits, as well as a thorough review of systems. The NCCN survivorship guidelines have a suggested survivorship assessment with 1 to 2 targeted questions per organ system, which can be a helpful framework, with specific suggestions for referrals and interventions if patients screen positive to any of the questions. A crucial component to consider for our gynecologic cancer patients is their risk of osteoporosis and osteoporosis screening. Gynecologic cancer treatments, including ovarian suppression, oophorectomy, and radiation, all increase the risk of bone mineral density loss and subsequent fractures. According to Hassan et al., in BRCA mutation carriers that underwent BSO before age 50, 62% were affected by osteopenia and 9% by osteoporosis. A review article by Sebeki et al., published in Gynecologic Oncology in 2021, highlighted that patients who undergo premenopausal oophorectomy experience bone density loss within 1 to 2 years. They provided practical recommendations for bone mineral density screening for patients with gynecologic cancer, including performance of a DEXA scan for high-risk patients within 1 to 2 years following cancer treatment. High-risk patients include premenopausal patients who undergo BSO, patients who underwent pelvic radiotherapy, and patients with an increased baseline fracture risk. These risk factors can include older age without recent screening, history of a non-traumatic fracture, long-term steroid use, rheumatoid arthritis, tobacco or alcohol dependence, low body weight, which ACOG defines as less than 127 pounds, or a family history of fractures. We can also incorporate standard risk calculation scoring tools to identify patients at higher fracture risk, including the FRAX score. The review article highlighted that CT scans are another way to assess bone mineral density. In 2022, Sobecki et al. Followed this by publishing an article in the International Journal of Gynecologic Oncology, analyzing the use of opportunistic CT scan bone mineral density measurements. For example, using scans performed for surveillance in patients less than or equal to 65 years old. They found that CT scans demonstrated bone loss at 1, 3, and 5 years out from treatment, and that half of patients who had normal bone mineral density measurements at the beginning of the study were at risk for osteopenia or osteoporosis at 5 years. They concluded that CT scans performed for surveillance can be employed to identify patients who warrant definitive imaging with DEXA to identify osteopenia and osteoporosis. As with all patients, it's important to discuss strategies to maintain bone mineral density, like weight-bearing exercise and appropriate vitamin D and calcium intake, as well as strategies to reduce fracture, like fall prevention.
Based on specific treatments patients have received, their risk for long-term side effects and complications will change. For example, some patients may be at increased risk of development of secondary malignancies, while others will have higher risks for osteoporosis and osteopenia. Another example is cardiotoxicity, especially in patients exposed to anthracyclines, trastuzumab, or chest radiation. Periodic cardiac assessment may be warranted. The NCCN's guidelines on survivorship recommend referral to appropriate specialty providers. In cancer survivorship literature broadly, qualitative assessments of survivor desires have yielded mixed results depending on the patient population, primary disease site, and other factors. The key takeaway is that it's crucial to tailor our survivorship care to our individual patients. An easy way to do this is to ask patients which pieces are most important to them. One study, published in Gyn-Onc Reports in 2022, did this with a survey model. Frequently mentioned concerns from patients included fear of cancer recurrence, ongoing side effects, and of a desire to lose weight. Survivors ranked assistance with nutrition, weight loss, and stress reduction as most important to survivorship programs. Results differed by age, with older patients less likely to report concerns about weight loss, sexual function, and strain in family relationships compared with younger patients. It's important to note that this survey was conducted in a largely white population, and these desires may not be representative for people from other backgrounds. Again, asking our patients what they need will help us provide patient-centered care. Another point to acknowledge is that the diagnosis of gynecologic malignancy, treatment, and surveillance visits can be traumatizing or re-traumatizing, especially for those with a history of assault, leading to significant psychologic distress. Treatment and sequelae of cancer, especially related to sexual health and body image, can result in depression, anxiety, post-traumatic stress disorders, and body dysmorphia. To help combat this, it is important to remain a steward of trauma-informed care. A 2024 review by Fulton et al. Provides a format for trauma-informed care to bring into working with gynecologic oncology patients.
The last piece of survivorship care is sharing information with your patients about what that care is going to look like. It's helpful to start these conversations while patients are still receiving treatment or at their first post-treatment visit so they know what to expect in the long term. You'll want to delineate who they'll be seeing for their surveillance visits, whether it's you, an APP or fellow in the clinic, or perhaps their benign gynecologist, what those visits will entail. Some patients are kind of surprised to hear that pelvic exams will be necessary, and advance notice is helpful for planning. They also might be expecting routine imaging, so setting expectations is crucial. It's also important to let them know if you're going to be involving other services in their care. As we've discussed throughout this episode, survivorship care takes a multimodal approach. Patients may benefit from involvement with pelvic floor physical therapy, general physical therapy, mental health specialists, nutrition, primary physicians, or subspecialists to optimize their medical comorbidities, specific sexual health clinics, pain management, and social work. One way to frame this with patients is, we'll continue to see you, but survivorship care also means building a team around you. And this reassures patients that they're not being abandoned after treatment ends. The NCCN and the American Cancer Society have great patient-facing survivorship manuals that you can share with your patients.
That's all we have for you today and this season. And shout out again to Sky for making this episode. We hope you learned something today on today's episode and throughout the core curriculum series of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Survivorship includes the individual with cancer from the point of diagnosis with a malignancy through their remission, any recurrences, and those who are living with metastatic disease. Survivorship is an active phase of care, including detection of recurrence and management of late and long-term side effects.
Surveillance is recommended following treatment for all gynecologic malignancies. The appropriate interval between visits depends on both the disease site and the individual's risk of recurrence. At each visit, clinicians should obtain an interval history, review of systems, and perform a focused physical examination. Imaging studies and tumor marker assessments should be reserved for situations in which they are clinically indicated. In general, visit frequency tapers over time, as the risk of recurrence is greatest within the first few years after treatment. Detailed site-specific guidance on surveillance schedules and components can be found in the NCCN and SGO recommendations.
Hormone replacement therapy is defined as physiologic dosing for premenopausal patients, and hormone therapy is lower doses for postmenopausal symptom control. Non-hormonal options for treatment of vasomotor symptoms are first line, with hormonal options reserved when needed. Vaginal estrogen is generally oncologically compatible with low systemic absorption. All conversations regarding hormone therapy should weigh tumor biology, age of diagnosis, and patient values.
Survivorship care is an interdisciplinary team effort. A survivorship toolbox, including visit framework, patient handouts, order sets and prompts, and a referral network, can be really helpful in managing cancer-related symptoms as well as multifaceted preventative care. This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson. We'd like to thank Dr. Janelle Sobecki, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney, Maya, and Sky signing off.